Welcome everyone back to part 2 of the development and analysis of human movement, shoulder. So we talked about a lot of the bony structures in the first section. So now we are going to go ahead and talk about most of the muscles. So just as a quick review, we talked about the scapula, but now let's really start labeling some of these pieces within the scapula. So we have what's called the glenoid fossa. Okay, so if you look here, it's right here. It's pretty much a fossa. Fossa means that something connects to it. So with this fossa, it means there's an articulation between that and the humerus. So that's what the glenoid fossa is. It's a depression within that bone that articulates with the humerus. Then we have the glenoid labrum. As I mentioned before, this really adds depth to increase its overall contact area between the glenoid fossa, or the labrum, or not the labrum, but the glenoid fossa, the glenoid, and the humeral head. So that's what that does. Then you have the subscapular fossa. That's on the anterior view here, and that's this big depression within the scapula on the concave side of that scapula that really articulates, and it's not articulates, but it holds the subscapularis muscle. You then have the infraspinatus fossa, which is on the posterior side, right underneath the spine of the scapula, and that is where the infraspinatus sits. You then have the supraspinatus fossa, which, if you haven't caught the trend by now, is where the supraspinatus muscle sits, and that's the superior portion of the spine of the scapula. You have the axillary border, okay, and that is the side of the scapula that's right up near your armpit, so the lateral aspect. And then you have the vertebral border, which is the medial aspect of that scapula, and that means vertebral, it's closest to the spine, and it's the border, so it's the border of that scapula. Then, when we look at the humerus, the parts of the humerus are the head of the humerus, that's this top portion up here, and that's the part that articulates with the glenoid. Then we have the shaft of the humerus, that's the long part here, full of cortical bone. Okay, the greater tubercle, that's up here, right there, that outside bony protuberance on our humerus that you can feel kind of right out here. We'll go over that in lab, but just so you know. Then you have the lesser tubercle, which is more medial to the greater tubercle, and that is where the subscapularis muscle attaches. And then when you look between, as we work on our palpations in class, you'll be able to feel a little depression between the greater tubercle and the lesser tubercle, and that is where your bicipital groove goes. So a lot of times you get a lot of biceps tendonitis in that area. And then also looking over here, you see between the shaft and the head of the humerus, you see that we have the anatomical neck, where the growth plate usually sits, and then we have the surgical neck, which is where you get a little bit of rotation around there. As that bone kind of torques, you can kind of see how you have these spiral grooves for your radial nerve, you have these little concave portions within the bone as they've adapted to the forces that have been applied through life. So I said earlier that in the part 1 that a lot of the stability in the shoulder joint is from muscles and the ligaments. So the ligaments form because we talked about how it's a synovial joint, right? So that means it has a capsule. In that synovial joint, there's a thin container that kind of surrounds the rim of the glenoid fossa and the anatomical neck, creating that. So you can really see that right here, and how you have that capsule right there. You have an outer fibrous membrane and an inner synovial membrane. The inner synovial membrane is what actually secretes that synovial fluid to lubricate the joint. It holds the humerus on the glenoid fossa because, like before we said, it's more like a golf tee on a golf ball on a golf tee. So if you look at it, it's like this ball here that sits on this piece of tape, and we have a little bit of articulation. But if I move it at all, right, see how it rolls all over? so we add some tape over it pretty much to hold it onto there. And that's kind of what the capsule does, is it holds that on. And because it is a capsule with synovial fluid, it does create a vacuum to help suction that bad boy on there. And then the rotator cuff muscles also help support and stabilize the humerus on the glenoid fossa. So as we look at the way the shoulder joint moves, we have a convex on a concave articulation. The convex humeral head moving on a concave glenoid on the scapula. So we have a convex on concave roll. Okay, so you have to remember that as we move. So we look convex on concave. As the head of the humerus glides posteriorly, the distal segment moves forward into flexion. As the humeral head glides anterior, that distal portion moves into extension. So you see how it's moving opposite. It says loose pack position is at 55 degrees of abduction and 30 degrees of horizontal adduction. So what is loose packed position? Well, we have two different types of positions we discussed before. We have close packed and loose packed positions. Close packed positions is where you have the most bone surface making contact, okay? So for this, loose pack position is when there is the least amount of contact within the joint and thus the most amount of joint play available. So that'd be at about 55 degrees of abduction, so arms out to the side, and then 30 degrees of horizontal adduction, so almost into that scaption area. And the end feel, which is what kind of feelings we feel when we stop moving a joint. We'll talk about it more in lab, but what it means is what's stopping that joint from moving any further within the joint. Is it ligaments? Is it muscular? Is it bony tissue? And those give you different end feels, and we'll go over that in lab to really hammer that point home. So the muscles of this shoulder. The diagram over on the left really gives us a good idea of what's actually happening here. So you can see the rotator cuff, how it kind of helps pull that humerus against the glenoid. And then we have the deltoid. What kind of force does that pull? It pulls a superior force on this humerus as it attaches on the shaft down here. And then if you look also posteriorly, you can see all the direction of pull of all the different muscles in that posterior. Remember we said earlier that the scapula gives attachment for 17 different muscles? Well, now we can kind of see how those muscles affect the scapula through daily activity. We have the levator scapula pulling this way, rhomboids, trapezius, rotator cuff pulling it that way, serratus anterior pulling laterally, deltoid pulling inferior, serratus anterior upper portion pulling upper superior and lateral, and trapezius pulling superior and medial. So you see how this scapula, really depending on what's firing, can go really any direction. So it's very versatile, and that's why it's not actually attached by any bone. It just kind of sits there and floats on our thorax. Most muscles originate on the scapula, clavicle, or ribs and insert on the humerus. Muscles crossing the anterior portion of the scapula or the shoulder typically have a vertical line of pull, and they'll flex the shoulder. Muscles crossing posterior aspect of the vertical line will pull into extension. Muscles with a horizontal line of pull across the anterior will internally rotate or horizontal adduct the shoulder or the humerus. Muscles with a horizontal line of pull crossing the posterior portion will externally rotate or horizontal abduct. Muscles crossing the superior lateral portion of the joint will abduct, and muscles crossing inferior medial of the joint will adduct. So now let's dive into what actually those muscles are. Right after we talk about what humeral head, what motions the humeral head move. So there's a glide, a roll, and then what we have called a force couple. So the humerus glides and rolls within the glenoid depending on what motion is happening. So for example, a glide, so when it's moving across like this, right, that's a glide. And that is an abduction. The humeral head glides inferior. So as I lift my arm sideways, that humerus, or there we go, this is better. My glenoid, my humerus, as I move it up, it glides down like that. okay? But it also has a little bit of roll. So it rolls and then glides. I'm trying to get a good camera angle for you. There you go. So it rolls and glides. Roll and glide. Roll, glide. Okay? And that's what happens with that humeral head. So it rolls over and glides down. Because remember, we don't have much contact being made on that glenoid. So the humeral head really has to articulate and move around and be dynamic as we ask it to do the many things we ask it to do. And then a force couple is made. A lot of these motions within the shoulder involve a force couple. What a force couple is where we have more than one muscle pulling in different directions to accomplish the same motion. So as we look at some of these muscles and what they do, we'll understand that they have different lines of pull, but they still create the same overall motion. Okay? So something to keep in mind. Now we dive in. So the trapezius muscle. Anatomically, it is one muscle, but functionally it has three different parts. So we have the upper trapezius, if you look over here, and look at these muscle fibers, right? So it's going to pull medial and superior on the scapula, mostly at the lateral portion of that scapula, near that acromion, right? And it also helps pull up on that first rib kind of area up there as well. So it originates at the occiput, so the base of our skull, and it inserts on the acromion process down over here. And then its main action is scapular elevation or upwards rotation. So you can see how these fibers would elevate that scapula because of the line of pull, right? And it would help if I pull up here, what's going to happen down here? It's going to come on out. It's going to rotate out and upward rotate. The middle section originates at the C7 spinous process. So right in here. It inserts at the spine of the scapula. So right along here. The action for that is scapular retraction. So you see how this is pretty much a horizontal line of pull here. So if I were to contract that and shorten it, what would happen? The scapula would move medially, right? And cause scapular retraction. Then we have the lower portion of this trapezius muscle, which originates at T4 to T12. Okay, so right in here, down in here. And it inserts at the base of the scapular spine, down in here, base of the scapular spine. And then its motion, or its action, is scapular depression. So you can see how these muscle fibers line up. So if I contracted them and shortened them, what would happen? It's going to come down, right? And thus depress that scapula and cause some upwards rotation as well. Because you can see how I would pull here, this could easily pull out a little bit right there too. And it would rotate out, because you got to think it's a triangle, so it's going to fulcrum wise. Okay? So almost like if I took this little card here, and if I pull down here, what's going to happen? Upwards rotate. See how that other end moves up? So that's what would happen. We also have the levator scapula. So you see this little guy attaches to these transverse processes of C1 and C4. Okay, these lateral protuberances off this vertebral body are transverse processes, and they insert at the vertebral border of the scapula, so down here. The action of this would be what? If I contracted these muscles, it would elevate the scapula while also downwards rotating, so bringing this distal end medially, okay, and downwards rotating. A lot of times this gets real tight on people, real tight. You'll see on each other when we play in lab and palpate, and you'll see that a lot of you guys have this bad boy that's real tender and real tight. We have the rhomboids. The rhomboids are two different muscles. We have the major and the minor, and they have the same actions. So both of them are the same. They just lay over each other. They originate on the spinous process of C7 to T5. They insert on the medial border of the scapula, and their actions are scapular retraction and elevation and downwards rotation. Because it is so broad, it does play a part in all of these. The serratus anterior. So if you look here, this is the anterior portion of our body, posterior back here. So it kind of goes underneath, right? It originates on the lateral upper 8 ribs, almost under our armpit kind of, and it inserts on the medial border of the scapula, going underneath it though. You see how the scapula is kind of hollowed out here, and it attaches on the medial border, and thus it protracts, so it pushes the shoulder blade forward, and it upward rotates that scapula as well. We could not lift our arm overhead without this muscle. It can be palpated with arm overhead, and it runs posteriorly between the scapula and the rib cage and keeps the medial border of the scapula against the rib cage. This will come and play a lot more during lab when we actually start palpating, and we can see some of these dysfunctions that I'm sure some of you guys have. Pectoralis minor. That guy originates on the 3rd to 5th ribs, and it inserts at the coracoid process, which is a little anterior protuberance on the bottom of the scapula. And the action of that is scapular depression, protraction, downwards rotation, and tilts. So while it's a very small muscle with 3 different bellies here, it does do a lot. It has 4 different motions there. It's the only muscle of the shoulder girdle completely located on the anterior portion of the body. So you see how the serratus anterior went lateral and then onto the posterior side. The pec minor does not do that. It goes right underneath. And it starts anterior and inserts anterior because that coracoid process is on the anterior portion of the body. We then have the deltoid muscle. The deltoid muscle has 3 different portions, the anterior, medial, and the posterior portion. The anterior portion is on the lateral 1/3 of the clavicle. It originates, and it inserts on the deltoid tuberosity in the middle of that humerus there. The action is abduction, flexion, internal rotation, horizontal adduction. Okay. Then we have the middle portion of the deltoid, and that originates at the acromion process and inserts at the deltoid tuberosity as well. And that also is involved in abduction as its primary movement there. But you can see how we have different lines of pull here, right? The anterior portion, the middle portion, and even the posterior portion, and they all help contribute to abduction. So that's what we're talking about when we talk about that force coupling. How yes, it's kind of in line here, but they all technically have different lines of pull, but they force couple to create enough motion to do the same action that we're demanding of that. The posterior portion of the deltoid muscle originates at the spine of the scapula and inserts again at the deltoid tuberosity. Its actions are abduction, extension, hyperextension, external rotation, horizontal abduction. So we have this inchworm effect that kind of occurs at this muscle particularly, where the middle deltoid is at optimal length with the arm at its side. If only the humerus moved in abduction, the middle delt would lose its power as it nears 90 degrees. But because of the scapulohumeral rhythm, remember, so as we start moving that humerus and that glenohumeral joint, at a certain point that scapula kicks in after about 30 degrees. Now that scapula starts moving 1 to 2 degrees as well, causing that scapulohumeral rhythm so that it allows that whole muscle to work. And then the acromion continues to move away from the deltoid tuberosity and keeps that optimal length while maintaining an effective pull. So because that optimal pull of that middle deltoid is happening at 90 degrees, what happens is the scapula starts moving so that it keeps that optimal pull by moving the acromion further away as it moves the arm further away, and keeps it at that optimal line of pull of about 90 degrees there. We also have the pectoralis major, and there's 2 portions of this. You can see here, one kind of goes inferior lateral, and one just goes medial to lateral, almost horizontal there. So we have the clavicular portion, that's this top little guy here, and that is on the medial third of the clavicle. It inserts at the lateral bicipital groove, right here, and the action is the first 60 degrees of shoulder flexion. It has a vertical line of pull when the shoulder extension makes it a prime mover at shoulder flexion. Sternal portion of the pectoralis major attaches, you guessed it, right at the sternum through the first 6 ribs, and then it inserts at the lateral bicipital groove again, just like the clavicular portion, and its action is the first 60 degrees of shoulder extension. The vertical line of pull with this, when the shoulder is in extension, makes it a prime mover of shoulder extension. We have the latissimus dorsi. It originates at the spinous process of T7 to L5. So you see here. It inserts at the medial bicipital groove, so it kind of comes around in here. And the action is shoulder extension, adduction, internal rotation, and hyperextension. It is mostly superficial and one of the easiest to palpate because it makes up so much of our posterior portion of our thoracic cavity. Then we have the rotator cuff muscle. An easy way to remember them is through the acronym SITS. Okay, so we have the supraspinatus and teres major, or that teres major here. That's the S and the T. So the teres major originates at the inferior axillary border of the scapula, and it inserts at the medial bicipital groove. Its actions are shoulder extension, adduction, and internal rotation. It travels along the latissimus dorsi through that axilla to the bicipital groove, and it does everything the latissimus dorsi does except hyperextension. Okay, so you see that little guy right there, and it just helps kind of jumpstart everything. Remember how we talked about how we have the small muscles with the less range of motion, and then we have the large muscles with that span a vast area that create more motion. So while this guy does all the muscles of the lat, it really just begins the motion where the lat picks up the rest of that. Supraspinatus, that's the muscle that sits up here in the supraspinatus fossa of that scapula. It originates at the supraspinatus fossa, and it inserts at the greater tubercle, right over there. And its function is abduction. It's important in stabilizing the humerus against the glenoid due to that horizontal orientation. So you can really see how this guy really sits in here and pulls that shoulder and that humerus into that glenoid fossa at the superior portion. Then we have the I, which is infraspinatus. So when we have SITS, it's SI supraspinatus, infraspinatus, teres major, teres minor, and subscapularis. So infraspinatus, it originates at the infraspinatus fossa, so you see it here, and it inserts at the greater tubercle again. So it externally rotates, horizontally abducts. It's mostly a superficial muscle, very easy to palpate as we'll learn in lab. It's important in stabilizing the headed humerus against the glenoid because of its line of pull. So you can see how we have the supraspinatus pulling it on the superior portion, and we have this infraspinatus pulling it on the posterior portion. And then we have the pectoralis that pulls it on the anterior portion, right? You see that there, it's pulling it in. So then we have the teres minor, which is the little guy right underneath it, right there. It's a little more superior. No. Try again. It's a little more superficial than the teres major, and thus it's a little easier to palpate. It originates at the axillary border of the scapula. It inserts at the greater tubercle, and it is responsible for external rotation and horizontal abduction. It's important in stabilizing the head of humerus again, just like the infraspinatus, pulling that line of pull there. And finally, we have the subscapularis that runs underneath the scapula. It sits in that subscapularis fossa. It originates on the subscapular fossa and inserts on the lesser tubercle, and its job is internal rotation. So as we look at the muscles that kind of connect to the C-spine and T-spine, you can see that the spinous processes and the spine is very important in the stabilization of the scapula and just the posterior chain of the shoulder as well. The trapezius muscles are most superficial and easiest to palpate. Rhomboids and levator underneath it are easy to palpate. And we have that force couple, kind of, again, just a reminder. Now that we've learned all these little muscles, we see how when we take the top layers off, we have these little muscles that all kind of create and start these motions and create some of that very powerful motions. And then we have the larger muscles that take over and create the end range power. Just a chart here to look at our prime movers are the muscles that have a primary function of the muscle listed. So in this chart we look at retraction, and these are the prime movers. These are the ones that are most responsible for it. While there's other that kind of help with that force coupling, these ones are the ones that actually have the most responsibility for the motion. And that is the end of section 2. So just to look real quick, we can see here on our muscle man, right? You see how we can really start looking at that, and I can hide some of these muscles here. We don't need that. You can see here the pectoral. Let's do that there. Right. So you can see how, I don't want to hide it, there we go. So like right here, the left pec major right there, and you see how it inserts on that humerus. The humerus is kind of hollowed out in this picture, I'm sorry. It is what it is. Let me take off this biceps because we don't need that on there. We don't need the triceps, don't need that, don't need that, there we go. And so you can see how they kind of really, look at that humeral head. It's hollowed out right here. There we go. Now you can see it. And you see how all these muscles really attach to create that. Look at how much muscular stability is created on the posterior chain here. As we look at the teres muscle here, and then the infraspinatus there, and then supraspinatus there as it comes across that fossa, right? Let me see here. You can't even see it on the back, right? Because this trapezius is taking over so much area. So when we take that layer off, now you can really see that supraspinatus, that infraspinatus, and then the scapula is right here. You can't even see it really because it's covered by so much muscle. Our rhomboids here, right? Just remember how I said we have 2 of them that do the exact same thing. These are our rhomboids. Here is our levator scapula, right there. You see that line of pull there, how it kind of twists and how it attaches to, let me hide that. How it attaches to our C-spine in there. Okay, let me see here if I can move this. And then you can look underneath. Here's our teres major and minor here. Minor, major, right there. See how they both have different kind of connections there though as well. Teres major runs underneath to the anterior portion. Teres minor over the top on the lateral portion. I want to take this layer off too. So you can see underneath, see our scapula, and you can see that subscapularis. Let me turn it off because you can kind of see here the hollowed out color of that scapula here, right? And look at that subscap that sits underneath, how massive that bad boy is, and how it cups around. You can see the curvature of it as it cups around to the anterior portion of that humerus, pulling it against the glenoid. So that really helps with that anterior stability with that subscapularis. And then we take that away, and now we're just looking here at our pec. So let me tilt it. There we go. We can take the pectoralis away. Now you can come in here. It's your pec minor. See how that attaches to that coracoid process right here? You see that? And then we take that guy away. And now we have our oblique. Let's get underneath. Let me hide the oblique real quick. There she is. And then we have here our serratus anterior, and you see how that guy kind of cuts across. I wish I can get rid of that while still keeping it highlighted. So you see how it comes across all the way underneath. I guess you can't see it because I hit it. There we go. And you see how it starts laterally here, runs underneath the arm, all the way along, hugs that thorax, those ribs, and attaches on that medial border of that scapula on the underside there. Okay, here's our lat and how it attaches right in there to the greater or lesser tubercle there, right near that bicipital groove. You can see that bicipital groove here in this picture here pretty well. Right there, greater tubercle, lesser tubercle, bicipital groove, right there. So that's a better look at those muscles there, and it also just lets you see how protected that shoulder girdle is with the muscles and musculature as it sits over there. Okay? So that's all I have on that. And yeah, enjoy, and I will see you guys in the lab. Take care. Have a great week.